Hello, my name is Dr. James Galloway. I'm a rheumatologist in London, and I'm also a researcher, and I am the analytics lead for a project called the National Early Inflammatory Arthritis Audit. This short video is to explain to you a little bit about the audit and to give you some understanding of what it is, why it has been done, and if you're asked to participate, what that might mean for you. Let me share some slides with you. So, the National Early Inflammatory Arthritis Audit is an audit that is run and managed by the British Society for Rheumatology. It's an audit that was set out to try and improve the way we care for people who develop conditions that we collectively call inflammatory arthritis. The most common example of this would be rheumatoid arthritis, but other examples include psoriatic arthritis or other what we call seronegative arthritis subtypes. But you'll hear me during the course of this talk predominantly about rheumatoid, as that is the most common example. But our drive is to improve care for everyone who presents for the first time to an NHS service in England and Wales with a new symptom that could be a disease like rheumatoid. So this is what I'm going to talk about. I want to give you an overview of what is NEIA, the National Early Inflammatory Arthritis Audit. I want to tell you who's being asked to take part, how we collect information and what information we're collecting, and then also just touch on the question of, are the data secure? Is it confidential? And do I have to take part? So quality improvement as a concept in healthcare is recognised that healthcare is complex, and giving good quality care depends on many different things. And our aim is to get the best care to the most people to really improve the health of our population. And to do this, acknowledging the complexity of what we do and all the many different bits, from how someone gets referred into a hospital system for an opinion, how they get to the hospital, how the hospital manages them, how the hospital can get them on treatment quickly. All of that, in order to do it well, requires us to monitor it, to, if you like, quality assure it, to continuously measure and track our performance and work hard to make it better. Now, in inflammatory arthritis, and in rheumatoid arthritis in particular, there's something very important about the early months of diagnosis and treatment. On the graph here, what I've done on the y-axis, the vertical axis, is plotted the severity of disease, and then on the x-axis, along the bottom, horizontally, time. And the graph depicts that if someone presents with rheumatoid arthritis, a disease of the immune system in which the body becomes inflamed and that can damage the joints, whether we catch you early or after a few months, we can control with medicine that inflammation and suppress the inflammatory component of the disease. However, the longer we leave it to intervene, the greater the risk that damage may have developed. So the inflammation can cause damage and destruction of the joints. And we've shown in many studies that actually the early weeks and months make a difference in preventing the development of irreversible damage within a joint. So if we leave that intervention till too late, people may become disabled and unable to retain the function they had in their joints had we not treated them sooner. And to treat someone quickly requires lots of things. It requires the person who develops the symptoms to know to seek help. It requires the primary care practitioner, their GP, to refer them rapidly through to a specialist. And it requires that specialist to be able to see them quickly and start them on treatment. And the idea that we strive was doing all of this within the first 3 months. So with really there should be virtually no delay between a GP referring through to the secondary care. The secondary care doctor should then see the person within ideally just a few weeks and start treatment within 6 weeks of making a diagnosis. And that whole time frame is where we say 3 months is our golden number. So what are we measuring in the National Early Inflammatory Arthritis Audit? What data are we collecting about people? Well, we collect information about all sorts of aspects about how people go through that journey. We also collect information about their symptoms. We ask people to complete a number of questionnaires which capture information about how well they can function, about their sleep, their pain, their work, and also their overall general well-being and mood, such that we can use this information to understand how different departments are not only getting people in quickly, but demonstrate that getting people in quickly corresponds to better outcomes. And I will show you a little bit more in a moment just about the flow of information. So who's being asked to take part? This is a photograph of King's, a hospital where I work, and on a sunny day in London. But I put this up just to say that pretty much anyone who comes to the door of our services in England and Wales who has been referred with a suspicion that they have an inflammatory arthritis is eligible to enter. It is for adults, so people aged 16 and over, people referred to rheumatology services. But other than that, we really do not put any exclusions on who we want to collect information about, because our goal is that we're providing high quality service for all. However, I should specify that the amount of information does depend on whether you are ultimately diagnosed with a condition such as rheumatoid arthritis. If you're not, then we only collect very limited information just to work out how quickly you were referred and how quickly you were seen. But if you had rheumatoid and you were diagnosed with that condition, we would also collect information about how quickly you started on treatment and how quickly you then got into a state of good disease control, and what medicines they used to do that over the first, and we collect information over about 12 months. So let me share with you how we do that. We have at the clinician end a portal. This is the front screen that they can log into, and actually anyone can go to this website. It's www.arthritis-audit.org, and in this website the clinician will have a unique login. When they log in, they will enter some information which will include if a patient's referred, when they were referred, what delays there were in the primary care referral, what delays there were in the secondary care referral, and then the delays, if they have rheumatoid, also in starting treatment. And we measure information when people are diagnosed, and then we ask for a small amount of information to also be collected and returned at 3 months and then at 12 months. The dataset also get linked nationally to the central NHS data system, what we call NHS Digital. And that allows us also to look at other things like admissions, complications of treatment, whether someone needs a joint replacement or should someone die, which is thankfully very unusual in our field. But all of this together and all of this information allows us to provide really robust estimates of performance and quality in different services around the country, so that as a community of rheumatologists, we can work together to learn from the people who do it well and to support the people who don't succeed in getting the outcomes they want. And all of this is done under the auspices of the Health Quality Improvement Partnership, which is this sort of national program that has set up to look at quality, not just in rheumatology, but across many disease areas. And in terms of that question I said, is your information secure and confidential? It absolutely is. The oversight of the project is very robust. So the information that is collected in a secure system, which is fully encrypted. That data then never leaves, so that your clinical teams obviously have access to your own data for the purpose of looking after you. But in terms of the analysis, that data never gets handed around to anyone. It's never sold to anyone. It's never passed on to people. It is turned into an anonymous data set for the analysis and for the reporting. And then the reports publish aggregate data. So it's summary estimates. So in a particular hospital, the average performance for everyone who goes there is this. It doesn't ever publish any individual data. But that said, I think we all do need to be very aware of what happens with information about us. And it is absolutely crucial. You really don't have to take part. And if you want to not be involved, when your team talks to you about it, just say that you'd rather opt out and they don't have to enter your data. We do encourage teams to try and recruit everyone, because the more information we know, the better we will understand that team's care and the quality of care being given. And our goal is to make the services better for everyone. But participation is absolutely voluntary, and so if you wish to opt out, you can just let your team know. And so how are we doing this? How are we actually making things better? The secrets to quality improvement, they're not really secrets. We've known this for a long time, but it is not about doing one thing. It's about engaging with lots of people, trying to work with trends, not against them. Trying to recognise that different departments will do things differently, so we need to balance standardisation with variety. We need to value how we communicate with people and trust how we work with teams up and down the country. And I feel very fortunate working in a specialty where I think this happens. And I think we're constantly looking at the audit to make sure we've got the right priorities, make sure that we're focusing when we look at individual departments, not about whether a person in the department is doing well or not, because this is not about putting blame on an individual. It's about looking at systems and processes and learning how we can do better, looking at what happens in good departments and where departments struggle and looking at what the differences might be. And I think we're incredibly careful about not saying that if we see a department's doing badly, that's because an individual person is causing that. That's not at all what this is about. This is not about sort of retribution or identifying someone and saying you've done badly. It's about saying what is going on and how can we help. And we know that audits like this, in fact, that the lighter the touch in terms of how much we do, less is often more on these things. We're not about big bang changes to services. It's about slow incremental improvement of what we do, because I think we are very fortunate in the NHS to have nationally really good pathways for people who present with rheumatoid. So that I hope I've explained to you a bit about the NEIA, and I will stop here. I hope you will go to the website, and if you are asked to participate, I hope you do feel you want to take part. Thank you for listening.